Welcome to Health Code Blueprint. Today, we're covering real-world case scenarios related to the nervous system and pain management, following Chapter 6 of the ICD 10-cm guidelines. In this session, we'll walk through the core definitions you need to navigate these encounters with confidence, including how to distinguish a condition from a symptom, how to identify the correct principal diagnosis, and what to look for in documentation so your coding decisions stay accurate and defensible. Disclosure. This presentation is intended for educational purposes only. It does not constitute legal, compliance, or billing advice. Always refer to official coding guidelines, organizational policies, and regulatory requirements when making coding decisions. Let's start with the central challenge in pain coding. Are we treating the underlying condition, or are we treating the pain itself? In ICD 10-cm Chapter 6, the hierarchy of principal diagnosis depends entirely on the provider's documented intent. So our job is to determine whether the encounter is focused on managing the condition or managing the pain. The rule is simple. If the encounter is specifically for pain control, a G89 code may be assigned as the principal diagnosis. If the encounter is for treating the underlying condition, then the condition code takes priority, and G89 is not assigned. This distinction drives sequencing and medical necessity. Here's the decision pathway coders rely on. If the visit is for pain management, assign the G89 code as principal and sequence the underlying condition second. If the visit is for treatment of the condition, assign the condition code as principal and do not assign G89. This aligns with the guideline that pain due to a definitive diagnosis is not coded separately unless the visit is specifically for pain control. Our first case involves a 67-year-old male with severe low back pain. Imaging confirms an L3 compression fracture. The documentation makes it clear. The encounter is for evaluation and treatment of the fracture, not for pain management. The pain is not described as acute, chronic, post-procedural, or neoplasm-related. Principal diagnosis. S32.030A, wedge compression fracture of L3, initial encounter. We do not assign a G89 code because the pain is due to a known condition that is being treated directly. This follows the guideline. Pain due to a definitive diagnosis is not coded separately when the encounter is for treatment of that diagnosis. Next, we have a 54-year-old female with a known displaced lumbar disc. She presents for a lumbar epidural steroid injection. The documentation states the purpose clearly. The visit is for pain control only. There is no diagnostic workup or treatment of the disc itself. Principal diagnosis. G89.29, other chronic pain. Secondary diagnosis. M51.26, other intervertebral disc displacement, lumbar region. Because the encounter is specifically for pain management, G89.29 becomes the principal diagnosis. This follows the guideline that G89 codes may be used as principal when the visit is for pain control rather than treatment of the underlying condition. Our third case involves a 62-year-old female, 3 days post-cholecystectomy, presenting with severe abdominal pain. The documentation tells us the pain is not routine for this stage of recovery. There is no postoperative complication. The pain is not described as chronic. ICD 10-cm defaults postoperative pain to acute unless the provider specifies chronic. Because the pain is non-routine and not due to a complication, G89.18 accurately captures the encounter. Across all three cases, the underlying condition is known, but the sequencing shifts based on the intent of the encounter. Case A. The focus is treating the fracture, the condition code is the principal diagnosis. Case B. The focus is managing chronic pain, G89 becomes the principal diagnosis. Case C. The focus is addressing non-routine postoperative pain, G89 is again the principal diagnosis. Ultimately, the why behind the visit determines the correct principal diagnosis. Here's a quick refresher on the G89 codes. G89.29, other chronic pain. Use when the provider documents chronic, and the encounter is for pain management. G89.18, other acute postoperative pain. Use when post-procedural pain is non-routine and not described as chronic. And remember, do not assign G89 when the underlying condition is the focus of treatment, unless the visit is specifically for pain control. When reviewing documentation, look for keywords that guide your sequencing. Pain control only or pain management, G89 is assigned as the principal diagnosis. Treatment of the condition. The condition code is assigned as the principal diagnosis. Routine versus non-routine post-op pain. Acute versus chronic descriptors. And the silence rule. If postoperative pain is not labeled as chronic, code it as acute. Pain coding becomes much easier when you anchor your decisions to 3 core principles. Intent is king. The reason for the encounter matters more than the diagnosis itself. Understanding why the patient is being seen drives the correct principle diagnosis. Sequencing impacts necessity. Whether the provider is treating the underlying cause or managing the symptom directly changes the medical necessity profile and determines how the claim is supported. Master the defaults. Know the ICD-10-CM defaults, like postoperative pain defaulting to acute unless the provider specifies chronic, so you can code accurately even when documentation is brief. Here are a few key definitions and reference points that support the coding decisions in this presentation. Feel free to pause the video and jot down any notes you'd like to keep. Principal diagnosis. The condition established after study is chiefly responsible for the encounter. G89 category. Codes used for pain when the encounter is specifically for pain control or when pain has a defined attribute. Reference sources. ICD-10-CM Official Guidelines for Coding and Reporting, Chapter 6, Diseases of the Nervous System, G00G99. Thanks for watching Health Code Blueprint. See you in the next video.